Well, thank you, May, and to the Planning Committee for inviting me to be a part of this program. I've not been to the APSF conference before, and I'm enjoying it very much. I was given a challenging topic to cover in 15 minutes, but fortunately, this has been addressed thoroughly this morning by Dr. Main and the other presenters. So my lessons learned will mostly echo what you've already heard, but I've taken a little bit bigger perspective, and we'll talk a little bit more about population health and societal impacts, and just to trigger some thinking about what we can do as anesthesiologists to address them. Disparities have been defined by the NIH as largely preventable health differences that adversely affect populations who experience challenges to optimal health. And this is important. They're closely linked to intergenerational, social, economic, and environmental disadvantage. And it's estimated that just 20% of health disparities trace back to the actual health encounter, the systems of care and response systems that we talked about this morning. And the rest is really attributable to social determinants of health that underline the health conditions that women bring into the health system, but also influence our public policy, resourcing distributions within our society, and the infrastructure and resourcing available in our health systems to create optimal care protocols and to deliver that optimal care. There are 6 racial and ethnic minority populations recognized by the NIH to have health disparities, and also groups with low socioeconomic status, underserved rural populations, people with disabilities, and sexual minority groups. Some of these are easier to study using administrative data, and because maternal mortality and severe morbidity are relatively rare, much of the research relies on administrative data, and so the bulk of the research is really focused on racial and ethnic minorities and some on socioeconomic status, with less research available investigating the other vulnerable groups. Notably absent from this list are immigrants and people for whom English is a second language. Now, those of us who take care of patients know that many people will have multiple marginalized identities, and that those identities intersect in a way that increase risk factors, synergistically increasing risk for adverse health outcomes. In addition, patients will have risk factors like advanced maternal age and obesity, and really it's the intersection of all of these risk factors that determine individual risk for adverse outcomes. Looking at the population prevalence of each of these risk factors, you can imagine that, in fact, it's probably the majority of delivering women have at least one marginalized identity. Now, we've thought about the impact of race on maternal mortality for many years. This is the kind of original slide from 1965 showing the remarkable decrease in maternal mortality in the United States from 1910 to 1960, and you can see the difference between black people at the top and white people at the bottom has been measured from the beginning, and that relative risk has not changed, but the absolute risk decreased as the total risk of maternal mortality declined. So improving outcomes for everyone has the potential to shrink risks if we're improving conditions equitably for all populations. Rates of maternal mortality continued to decline through about 1980 when they stabilized and then started to increase in the 1990s. And we've talked about this peak that happened in 2021 with Delta variant of COVID-19. And US maternal mortality rate peaked, according to the NCHS, at 23.8 per 100,000 and then subsequently declined to 18.6, which is comparable to rates before the pandemic. For Black women, the ratio peaked at almost 70 per 100,000 and then declined to 50 per 100,000. And so the most recent data from 2023 suggests a risk ratio between Black and white people of 3.5-fold risk in maternal death. The trend lines for Asian and Hispanic women kind of mirror that for Black women, and interestingly, in the most recent data from 2023, their risk of maternal death is slightly lower than that for white women. You should know that in addition to these racial and ethnic disparities, there's also tremendous geographic disparity in maternal mortality in the United States, with California being a leader. They're reporting here a ratio of 10.5 per 100,000 as compared with Tennessee at 41. And you can see that cluster of high-risk states in the South that includes Arkansas, where the maternal mortality ratio approaches or exceeds 40 per 100,000. Now, I sit on the Maternal Mortality Review Committee, and about 18% of the delivering population in Arkansas is Black, 13% is Hispanic. We have large, and it's over 65% are white people. And what's interesting is that the ratio of maternal mortality between Black and white people in Arkansas is only 1.2 for the years 2018 to 21. And outcomes for Black people are really commensurate with the national average. And what's remarkable is this very high rate of maternal mortality among white people in Arkansas. And I think it reflects some vaccine denialism and the fact that this took place during the years of COVID-19, but it also reflects a very high risk that we see amongst residents of rural counties in Arkansas. The numbers on this slide are incredibly small, so we have to be careful about overinterpretation, but just a general theme that I see is that mortality ratio in central Arkansas is commensurate with the national average, but all of these rural quadrants of the state have ratios between 30 and 60 per 100,000. And so I just want to bring to your attention the risk of maternal mortality that we're seeing in rural populations. Now, Northwest Arkansas is interesting because it's among the fastest growing metropolises of this country. Benton County is that county at the top right corner. It is in the top 20 most wealthy counties in the country. It is headquarters for Walmart, Tyson Foods, as well as J.B. Hunt. And it's the home for Alice Walton, who's the heiress of the Walmart legacy, and she's world's richest woman, estimated at $117 billion. Interestingly, within 30 miles of her home, there's a community of Marshallese people, about 12,000 people who immigrated from the Marshall Islands to escape nuclear fallout in the 1980s and 1990s. And the U.S. conducted its atomic testing in the South Pacific, and that contaminated those islands. And so this population of 15,000 people live and work in Northwest Arkansas. They are workers at the meat packing plants, and they were among the demographic, or the people who were most impacted by some of the outbreaks of COVID-19 in the meat packing industry. And so you can think that it only takes a couple of those people to have pregnancy-related deaths to impact that region's maternal mortality ratio. And I tell this story just to illustrate that I think going on in America is this widening disparity of wealth and equality that's probably underlying some of the statistics that we're watching. Another issue in rural health is the closure of maternity hospitals. This is from the Obstetric Anesthesia Workforce Survey, which is out, I think, this month or next in Anesthesiology. And between 1981 and 2023, you can see a pretty stable total births, not much change there, but a decrease in delivering hospitals from over 4,000 to less than 2,000. And in fact, since 2020, we've lost over 1,000 delivering hospitals in the US. And that has created what has been called maternity care deserts. These are counties with inadequate access to obstetric delivering hospitals, as well as obstetric providers and prenatal care. And as a result, qualitative analyses with residents of rural communities and my own clinical experience suggests that folks put off prenatal care. They do not want to come into the major centers. Even when they get sick, they worry about being admitted and being separated for long periods of time from their families. Many of them have responsibilities at home that they can't neglect. And so we're seeing a delayed presentation of care. So we've talked this morning about increasing comorbidities in the population of people becoming pregnant, and that really sets women up for increasing risk during pregnancy. I was part of this group that looked at racial and ethnic disparities in severe maternal mortality in the nationwide inpatient sample, and analyzed a group of an estimated number of 13.5 million births and found 218,000 cases of severe maternal morbidity. Interestingly, the rates were increased looking at the full composite that includes hemorrhage or includes blood transfusion on the left of this slide. But then when zeroing in on severe maternal morbidity without blood transfusion, the risk differences were really decreased. And that suggests that the magnitude of racial disparity reflects differences in blood transfusion. And as Dr. Main said this morning, focusing on anemia in Black women and Native American women, and then focusing on supporting intended vaginal birth and avoiding surgical injury with cesarean delivery may be probably the most effective means to impact racial disparities, at least as it pertains to severe maternal morbidity. This group looked at the Premier database and rates of severe maternal morbidity in about 11.5 million people who delivered across 1,200 delivering centers between 2008 on the left and 2021 on the right. And the unadjusted severe maternal morbidity rate increased progressively. You can see lots of bouncing around. And then this spike at the end reflects the impact of COVID-19. And then they did a risk adjustment for comorbid disease that people bring into the pregnancy or non-obstetric complications like COVID-19. And that risk adjustment really smoothed the line out, but you can see there continues to be a steady increase. So there's steady increasing rates of preeclampsia and complications thereof and cesarean deliveries as a result likely of the increasing comorbidities that people are bringing into the pregnancy. They stratified that analysis by vaginal birth and cesarean delivery, so the bulk of the increase. So in 2021, I believe the rate of severe maternal morbidity in cesarean deliveries was estimated at 3% versus 1% in vaginal births. So again, supporting intended vaginal birth, being thoughtful about treating anemia and avoiding blood transfusions, but also when we do cesarean deliveries, supporting timely cesarean delivery and then thinking through antibiotic prophylaxis and getting SCDs on patients and doing all of the safety checks as we go through so that we protect maternal safety even though we're hurrying to get babies delivered is an important part of addressing severe maternal morbidity for this audience. This group also stratified that trend line by race and ethnicity, and they found something interesting. The ratio is increasing for white women in orange and less so for Black women in light blue, but they saw dramatic increases in the much smaller population of Pacific Islander women in cerulean blue, in Native American women. Should I keep going? In Asian women and in Hispanic women. So these subpopulations have rapidly increasing rates of severe maternal morbidity that are not well explored or thoroughly explained in this analysis, and I think we need better data to understand what's going on in those populations. I want to move us along and pivot to use of neuraxial labor analgesia, since it's, that is an area of focus for obstetric anesthesia, and because multiple studies have demonstrated decreased use in both Black and Hispanic women. Interestingly, this randomized trial published in Anesthesiology by Brandon Tagioka showed they had a cohort of 200 women that they randomized between a comprehensive language concordant education program that had both a video as well as an instructional pamphlet, but probably most importantly, they did individual counseling with shared decision making to explore the individual concerns that the patient had and to address them. And they showed that among the 50% of the group that were Hispanic, that intervention increased use of epidural analgesia from 60% to 80%. No difference in the non-Hispanic population, probably because their use rate was already quite high. And reflecting on those conversations in counseling, they were addressing many concerns around trust in the health system, worries about paralysis, and worries about back pain. And so that suggests that underuse in these vulnerable populations is less about empowerment and going after that natural birth, and more about distrust in the health system and fear-based decision making, and that a little bit of extra time and effort from anesthesiologists to address those concerns in specific will close the gap in terms of access to labor epidural analgesia. Jean Guglielminati and his team was interested in looking at the effect of structural racism on labor neuraxial analgesia use, and this is their theoretical diagram that links through structural, institutional, and interpersonal racism and how the mechanisms by which each of those variables might influence labor neuraxial analgesia rate. And just as an example, one can speculate that in a health system that's relatively under-resourced, there may be less subsidy for the anesthesia group, and therefore the anesthesia staffing is going to be relatively tight as compared with the workload, both on the L&D unit and off the unit. And as a result, the team members are going to be spending more of their time off the unit addressing needs in the main OR, codes, and other responsibilities. And so even though labor neuraxial analgesia is available in that hospital, it may be less readily available when people need it. They pulled data from U.S. birth certificates from 2017. There were 1.7 million certificates that they analyzed, and they applied a validated index of structural racism to the county of where the delivery happened. And that index looked at 3 bad things. It looked at the population rate of those 3 bad things in Black people versus in white people in that county. And when that ratio of incarceration, low education, and unemployment was very high, that was a county that was designated as having the most structural racism. And you can see that that is indeed correlated with reduced use of neuraxial labor analgesia by 28% in Black people and by 15% in white people. So structural racism, it appears, degrades the quality or the ability of institutions to deliver neuraxial analgesia for everyone with impacts that are disproportionate for the most vulnerable populations. And of course, neuraxial labor analgesia is such a useful tool for anesthesiologists because we can extend that to provide anesthesia for cesarean delivery and thereby reduce the need for general anesthesia. And there's evidence from the MFMU network, which is a network of NIH-funded randomized trials in academic medical centers, so best case scenario locations, and even in those settings, there's evidence for increased use of general anesthesia among Black women. Now, this single center analysis from Northwestern is interesting. They looked at EHR data between, I want to say, 2007 and 2018 of 35,000 anesthetics. They identified a GA rate of 5% in Black women and less than 3% in white women. But when they did the sub-analysis, looking just down at the women who entered the OR with a labor epidural catheter in situ, they saw no difference in the incidence of general anesthesia. So we have an opportunity to partner with our patients, with our obstetricians, to really figure out who is most likely to need cesarean delivery and to do shared decision-making to help those women consider the benefits of epidural analgesia. But then we also have a responsibility that once we put those epidural catheters in, that we are rounding on the catheters, that we are paying attention to the catheters and ensuring very, very high quality labor analgesia, both because that will improve patient experience and satisfaction for labor, but more importantly because high quality labor analgesia is the most important predictor for successful conversion to anesthesia for cesarean delivery. And we know that Black race is among a whole host of risk factors for failed neuraxial anesthesia and pain during cesarean delivery. And I think this will be a topic for later discussion, but I just put it in front of you today that there's evidence that vulnerable populations in particular can have intraoperative pain dismissed and not prevented, and indeed in those cases it's probably most appropriate to go ahead and convert to general anesthesia. And one of the great legacies of APSF is how safe we've made general anesthesia, not just for non-pregnant, but for pregnant people as well. And I think the tools of video laryngoscopy and pulse oximetry, and we're going to talk a little bit about that more in this panel, have been really instrumental in improving the safety of general anesthesia. So I want to move us along and get us to the next speakers. I offer just a few key takeaways that disparities in mortality and severe maternal morbidity are persistent, they're prevalent, but they're highly variable in across health systems, across geographic parts of the country, and it really needs to be addressed at the local level. There are very complex interactions between all these social determinants of health that are far upstream from the clinical encounters. And so when we are taking care of patients, there's recommendations to really take a patient-centered view and to consider each individual patient and all of their complexity and the risk factors that they're bringing forward. With obstetric anesthesia, attention to equitable access to neuraxial analgesia is just the beginning. We really need to focus on the quality of that analgesia and ensuring appropriate use of neuraxial anesthesia for cesarean delivery. I thank you for your attention, and I think, is it Dr. Vaidyanathan is next?